You're muted, Chris.
I should know that by now. Sorry. I just want to say good afternoon. It looks like it's a minute past noon. Wanted to check that people could hear us okay. Thumbs up. We'll give them maybe another minute or two for people to join, and then get started. Everyone have a good Thanksgiving.
Mhm.
Hard to believe it's December. It was late this year. It's already well into it.
It was quick. Came quick.
All right, what do we think? 12:02? Should we start with introductions? Um, this is the second meeting of the Hospital Discharge Challenges Work Group. Welcome to everyone. We did introductions last time, but I know we have a few new people joining. If you could just raise your hand if you're new here, and we'll just give you a minute to say hello, like maybe your virtual hand if you have a chance so I can see you. But I do see a few people here. So Gina Kostian, do you want to say hello and introduce yourself?
Of course, yes. So hello, everyone. My name is Regina Costin, but please feel free to call me Gina. I am a researcher and assistant professor at the Department of Emergency Medicine at UConn Health. So thank you for inviting me to join this meeting.
Thank you. Jody.
Hi, good afternoon. Jody Terranova. I'm the Chief Medical Officer for the Medicaid program in the Department of Social Services in Connecticut. Sorry, I missed the first meeting. I was actually in DC at a Medicaid meeting. Thanks for letting me be part of this group.
Great, welcome. Bob Duncan.
Good afternoon, everyone. Bob Duncan, Chief Operating Officer at Connecticut Children's.
Okay, great. Do we miss anybody else who's new here? We did record the first meeting. I believe it should be available on YouTube, so if you need to catch up with that. So thank you and welcome again to everybody. Very quickly, just going down the agenda, we had some housekeeping items. Just wanted to check. There is a shared drive. We are trying to put materials in there. It was sent out by Peter. And there's also a website where we're sort of tracking the progress of this group. So I guess I just wanted to offer the opportunity if anybody had any difficulty accessing that or had any questions about that. And Peter, I don't know if you want to provide any updates on how we're going to use those resources. Use there.
Hello, can you guys hear me okay? Yeah.
Yes.
So I got an email from Lorraine earlier about how she couldn't access the link because it said it was expired. So I've updated the link with a new expiration date because I think there's a policy within the CGA where it's 10 days expiry. So I'll resend the link every week so you guys can access it. So I've updated it, and if you guys are able to access it, just email me saying it's okay. And if it's not, I'll send a new link after this meeting. So thank you.
And certainly feel free to email me if you have any materials you want to add. I can add that. I'm going to try to keep up with the shared resources. I have like a separate drive that has all the other stuff, but I'll try to put stuff in there. So any other questions on that? Great. So the next item on the agenda, and Jen and I, Jen Philippone, our co-chair here, have discussed this a little bit over the last week, and we just wanted to kind of revisit and make sure we're all on the same page regarding the scope of the work group. One of the issues that comes up is certainly, when you're talking about patients in an acute care setting, there's the opportunity to prevent people from coming in, being admitted. And that is certainly an area of, interest in, the overall healthcare landscape. But as far as this group goes, we did want to just kind of define the scope as people who are admitted but can't get out. And the other sort of subset of that would be readmissions, meaning people who bounce out of the hospital but come back too quickly in a way that really is not somebody who had an avoidable hospital day, or at least they came back. And I know that's of great interest to the hospitals. There's some CMS implications for that. So we just wanted to offer that for sort of discussion and consideration as far as the scope, that we're really trying to define and address issues regarding patients who are already in the hospital but can't get out for some reason. That, you know, they don't necessarily need to be in an acute care setting, but we can't figure out how to get them out. But would also include within our scope if there are issues that are causing people to be discharged too quickly or bounce back. So I'll pause there. If anybody, raise your hand if you have any questions or comments on that. Okay.
I was gonna say, thanks, Chris. I think, we talked last time and there's so many things that we could address, but our time together is short and our charge is limited. So while these are all important things, we want to make sure that we're getting to the crux of the matter that we've been asked to look at. So thank you.
Great. And the second area in that scope is thinking about, what's going on within internal hospital processes versus actual state level barriers. There are certainly things that probably any hospital could do to economize and make more efficient their processes to get patients discharged when they need to. And we certainly support those and would love to facilitate communication about that. But given that we have the opportunity to bring together people from around the state, and I also want to recognize that we do have our representative, Senator Saud Anwar and Representative Krista McCarthy-Vahey here, that we'd like to focus on state level solutions. In other words, barriers that hospitals are facing, whether that's resources, legislation, or legislative relief, rather than talking too much about possible internal hospital processes. So Jen, any other comments on that?
No, I think you said it well. We want to make sure that everybody's on the same page. We could certainly all get together outside of here if we needed to talk about what's working in some places and not others, and share best practices. But again, I think for the benefit of this group and as Chris noted, we have some great minds here from across the state in various settings that we can work together on addressing those things that are common to all of us. So thank you.
Okay. Any other questions or comments on scope?
Chris, if I may, this is Donna Hanley. I'm the president of the East Region for Hartford Healthcare. And I think there are categories of barriers that are statewide that are outside of the hospital's control. And then ultimately breaking them down into those categories. During COVID, we had the blessing of not needing authorization when a patient was ready to be discharged and was approved by the receiving facility, waiting for authorization from the insurance companies. It's a barrier for us. I think the whole undocumented, not anecdotally, but the undocumented population, all of us have patients that have been in our hospitals for a year, 2 years, 3 years. And, that's like a BHAG. That's something that I'm not sure we can solve, but I think it is clearly an issue that backs up our emergency departments. And I think thirdly, in particular parts of the state, we're more limited in either skilled nursing facilities or facilities that can really take, discharging patients that have family who've said, I can't do this anymore. So I think looking at resources, and ultimately, I think it's, in certain parts of the state, our ability to recruit and retain staff, to keep beds open in SNFs and nursing homes, rehab facilities. I mean, there's just so many different opportunities to improve, the ability to discharge patients.
Absolutely. And I think, yeah, we're definitely going to talk about that. That's going to be probably a lot of what we do over the next couple of weeks or more. Our intent with that first agenda item is just to define the scope, that it really is looking at things, all of those things that you're mentioning, Donna, that are, outside of the control of the hospital, but could potentially be addressed at the state level.
Thank you.
And that kind of takes us to our next agenda item. I spent the last couple of weeks trying to meet with people and get a better understanding of what we do know about, avoidable hospital days. And we could talk about that definition, but I think that's really the issue is patients who are in an acute care setting but don't need to be, and how do we move them to the right place? So, and I took this on from a few different perspectives. I did meet with OHS, Ross Dingle, who I don't know if he's here today, hopefully. Yeah, I see him right there. We also met briefly with CHA. Marcy Mitchell is here. I also had a chance to meet with the director of the Yukon Center of Aging and get some information or data from her. But I will just say it's been very difficult for me to get a handle on anyone who has data that really quantifies those categories, Donna, that you're talking about. I know it's very different from hospital to hospital. So I guess that's sort of the next agenda is really defining and understanding the Connecticut landscape is on the agenda. So first of all, I guess I'll just say we want to define avoidable hospital days, but each hospital may define that a little bit differently. And then I put on the agenda just to maybe comment on that, like what we do know. And I know we had these discussions, and I'll just put people on the spot a little bit. But Ross, do you want to comment on what OHS knows about avoidable hospital days and categories and what may be coming at some point?
Let's see. So I met with you. I talked about the two main data sets that I handle. We handle patient data, which comes directly from the hospitals, and we handle the all payers claims database, which comes from insurance payers. I talked about a few of the variables that we do have. We do have in some instances whether a patient was previously admitted. We have data on length of stay. We have data on how they were discharged, where they were discharged to in a broad sense categorically. I think in our initial conversation, we struggled to find exactly what you wanted. I do have something that I can share to the group later. I guess OHS has done a report. Let me pull it up so I know exactly what it is. So it's hospital readmission penalties, which I guess is a nationwide CMS thing. And that gives us more data on costs incurred by readmissions. They sort of index it based on a few standard conditions that people can be readmitted to. So there is some sort of data out there. So I certainly think we have some stuff to work with.
Okay, that'd be great if you're able to share that. And just to move along, Marcy Mitchell also put you on the spot with CHA, and we did have a conversation about this, but also just for the group, what we know from CHA data.
Yeah, we did have a conversation about trying to understand and better quantify some of the discharge delays. The topic of an avoidable day is still nebulous and a little hard to grasp, so I look forward to having this group's input on that later. But within CHA, we have been working with a throughput and discharge delay work group for the last year. One of the things that work group did is verbalized a lot of their largest concerns, or the things they feel that impact their discharges the most. The list is numerous, but we were able to kind of group everything, I would say, into about 14 relatively large categories. And so I'd be happy to share that list with this group, so we can kind of see if any of those might be something of interest. We are using that list with the hospitals currently to see if they are able to begin to track discharge delays by those reasons so that we can better quantify that. But we're still working through, this is a large ask for a lot of our hospitals. Our workforce is very busy and at capacity as is. And so asking them to document one more thing is a large lift for all of them. And so we're still working with many of the hospitals to try to implement some of these changes. So that is coming, I guess I would say. So we don't have that yet. From a CHA perspective, with data, we do have a lot of the similar things that Ross was just kind of going through from a patient perspective. And we might have an opportunity to think through how else we might define readmissions. My thought was outside of just the CMS definition, I wonder if there's a way to kind of think through where patients are going to and coming from, and not just if they're being readmitted, but are they revisiting the ED, even in the lack of admission. So just some thoughts about, CHA would not have that data readily available, but it's potentially something that could be done.
Okay, well, thank you. And I certainly appreciate anything you could share. I think, the 14 categories might be a great place to start if you've had a group within the CHA that has discussed that already. And Ross, similarly, if you have anything else to share, go ahead, Jen.
So thanks, Marcy, and thanks, Chris. So I happened to sit on that group with Marcy and several of the folks. I think some of the folks on this call actually participate in that as well. And I think, the challenge and the opportunity is, I think the list of 14 is precisely a great place to start, Chris. I agree with you there. I think all of us would agree, not only how do you define an avoidable delay, but how do we capture real data around that, is difficult. And so I think having that discussion with the folks on this call will be important, so that we can figure out how do we articulate what we believe is a problem in a meaningful way. That's not anecdotal, but that's also not requiring all of us to start to track more data in different ways that presents a different host of problems for us.
Yeah, I mean, I would say I try to come at things from a data perspective. I would love to have that data, but I also understand the burden that puts on there, and also just the challenges of definitions. So certainly the CHA is a way to go. Is there anyone else who has any suggestions of places in the state or people that may have objective data around this issue? I'll just throw that out there if I'm missing something. So my other thought on this, and Jen, I don't know if we even talked about this, but would be to try to actually survey this group, and put something together that maybe does have the categories that were talked about. And I'll pause there since Senator Anwar has his hand raised.
Sorry, Dr. Moore or Chris. Actually, I think the CHA may potentially be able to get the data from the hospitals. And every hospital has a care management department, and they should ideally be tracking the missed opportunities or lost days or days where discharge was not done in a timely fashion, and they find the causation of it too, and they can summarize it. So it would be without the patient information. So theoretically, it can help. And then perhaps if they go to CHA, they can even not mention the hospitals, but give us an insight into what the causation may be. We can get something, and then perhaps there's opportunity to get care management departments have a qualitative conversation too if we don't get data. Just a couple of thoughts.
I don't know if Marcy, you have any comments on that, like where we might go with that?
I was actually, Jen, sorry, Jen, I'm going to put you on the spot.
Yeah.
Where would care management, because I'm trying to think, the struggle that we've been having is that the data exists, but it doesn't exist in the EHR today. And so being able to get a stream of that data or to have it in one place or defined by a consistent set
Yeah.
of rules has been the challenge. So I don't know, Jen, if that, I mean, is that safe?
You depicted it very accurately, right? So it in some places it is tracked in the EMR, but not all. We don't have a single EMR. I think folks on this call are certainly aware that we don't all use the same EMR across the state. And so there are other disparate systems where folks may track that information. Again, I think Senator Armour, you said it the right way in that we have it somewhat anecdotally. Some may keep it in a handwritten list, some may keep it in another database. And so how do you then, and I think that's the challenge Mercy's been having with the work group, is how do you assimilate all of that information? It is absolutely directional. right? What the information that we know, and I do think your suggestion at potentially meeting with a core group of some of the care management directors might help us with this as well. And we've talked about that at the CHA work group. It's directional. It just won't be some of that specific data where we could say, we know that this particular delay, it can be attributed to X number of days, right, of someone's hospital stay. And provided that we don't need to get to that granular level, I think that the data and the information that's out there will be useful to this group.
So certainly, I mean, I'd love to have comprehensive data, but given the difficulties with that, I think we'll do our best. But it doesn't mean we can't look at solutions without having exact data. But I guess first of all, just on the problem side, what would people think of a survey mechanism for this group? Meaning, we have a very good group here. We have 25 people on this call right now, and they bring diverse perspectives about what the problems are. I think people wouldn't be here if they didn't think there was a problem. But maybe an opportunity for everybody to weigh in on what they think are the top five, or I would work with Jen to structure like a survey for the group to first of all understand the problems, and then also probably incorporate, what are your top five solutions that you would advocate for, and then we get a sense of where everyone's coming from, similar to what Donna shared, some of the issues that she sees, and I think certainly those are going to be some that bubble to the top, but I think everyone might have different perspectives. I know behavioral health is a whole other issue that we need to look at. We have a meeting coming up with the homeless coalition in Connecticut, and that's certainly an issue for getting people out of the hospital. So I think even if we can't quantify it exactly, if we can get a sort of a consensus from this group about what are the top issues to address, and I think maybe a survey mechanism would be the best way to do that. Jen, I see you took yourself off mute.
Yeah, well, we can certainly try and make it as painless as possible, right? But I also, I think to your point, everybody's perspective is important. Mag and Tracy are kind of in my screen right now, and I think that really not only us as hospital providers knowing what we're seeing, I think from the opposite side, right? Our post-acute care provider partners actually see some of that stuff differently than us. That's really important and informative to the process. So I agree with you. I think the varying perspectives of this group will be important to really hone in on what do we think those most important opportunities are that affect all of us that we might be able to address.
I like the idea of bringing structure via a survey to efficiently and effectively gather and collate that data to hopefully feed some actionable steps from there.
Okay, I hear a couple voices in favor. I saw some heads nodding.
Yeah.
We'll take that as a consensus. And if we have time on this call, I know we have till 1. We may, maybe I can open up a document. We start to spitball a little bit about, which categories to put in there. I don't know if Marcy, you have those 14 at hand, if we could, start to go through them. But the other, side of this is to really think about parallel solutions, meaning, is there a particular barrier at the state level? And I hear certainly there's resources, Medicaid payments, there's staffing issues. There may be some legislation or legislative relief around, some of the issues that delay people from getting out there. Senator Anwar.
So, sorry again. I think, Chris, one of the option is that this is well studied and there's a lot of publications for US healthcare systems, and perhaps we can do a survey of the individuals in this group, but there is plenty of data that's available on the causation and the percentages that's there. I'm just doing a quick little search on that, and it would be worthy to look at some of the published data and look at it from that perspective, and as well just to add more published information from New York or regional or Massachusetts hospitals, and perhaps use that as a guideline to while we do our own survey. Just an additional thought.
Yeah, 100%. And I have a large folder with all the stuff that I'm gathering around this issue. And I would welcome anybody, Senator Anwar, you found stuff, email it to me. We'll throw it in the folder. We can put it in the shared drive. But I'm looking towards, how do we write this report for the legislators in the state? And absolutely including literature and data from other places will be essential, and that would be a part of the report. So anything people have that they want to throw in there or discuss, we can discuss it in a meeting if needed. But I do think the benefit of this group is that we have a lot of expertise with people who have granular experience, what's going on in Connecticut and how we could address that. So I wouldn't want to squander that opportunity to ask this group for what they perceive as the problems and solutions. Does that make sense? Okay. All right, other thoughts on that?
I just wanted to mention if we're doing that and collecting this information and doing it to inform, say, the legislature, who's not as informed as this group, it might be really good to put it into different categories because you're going to get feedback on different issues some are going to be federal issues, some are going to be, industry issues, some are going to be, hospital issues, some are state statute, state regulation issues. So it would be really helpful, I think, to put it into the various categories as we receive the information back. And then we can focus on the state issues and inform each other of the other issues, right? Because what's a barrier to discharge to you is a barrier to admission for me and Tracy. So, and I don't think people understand that who aren't on this screen right now. So so that was just be a suggestion.
100%. Well, let's see. I wonder if I can share. Let's and I don't know, Jen, stop me if you want to move to something else, but here's a blank document, right? And we start to put these things in and just spitball. This is a brainstorming session. So I heard, from Donna, for example, prior authorization, what happened in COVID, and that is something that certainly is federal at the Medicare level, but could be addressed at the state level with Medicaid or other things. I heard about undocumented care or care for undocumented persons. I've heard about skilled nursing facilities, whether that's staffing issues. So why don't people raise their hands or Marcy, I don't know if you have a list of those 14 things. Try to put these together and.
Would it be helpful? Do you want me to drop them to the chat?
Sure, or you can share.
I was gonna say there's no chat. So we have prior auth, which you have on there. We have undocumented, uninsured / underinsured. We have legal / conservatorships. Lack of follow-up outpatient or home care. Lack of bed availability. This could be SNF, it could be behavioral health, it could be, we were not trying to be prescriptive if it's LTAC, etc. LTAC being long-term acute care hospital. Transportation. Sorry, I'll give you a second, Chris. These next two kind of go together. The one is primary behavioral health, and the second is comorbid behavioral health. The difference between these is whether or not the individual has, say, a substance use disorder or psychiatric disorder, and the second would be an individual with, say, dementia covered with coupled with a potential behavioral health disorder.
So primary behavioral health would be someone who that is the primary.
That is the primary reason why there is a delay. So it would be placement in schizophrenia and needing some sort of placement versus having the primary be dementia and then there being a secondary behavioral health issue. I know, Bob, you have your hand up.
Yeah, just for clarification, the legal conservatorship issue, would that include DCF, the state and DCF in that component?
My next category is state agency. And so that's a great point. This is where this gets tricky, right? Because some of these are not clean, right? People have more than one of these at any given time, and so that does get tricky there. Yeah, so it could be DCF, could be DMS, could be, a number of different agencies. Yes, DSS. The next one is medically complex. So this includes patients who are on trachs, vents, medically fragile, specialized pediatric needs, dialysis, those sorts of things. And then we have no caregiver. I'll give you a second.
No, go ahead.
It's no caregiver or lack of family cooperation. So this could be where the family intervenes and is denying every placement that you see or is refusing to take responsibility for their loved one. The next one, we only have a couple more, is Title 19. It got its own category because if I got paid $1 for every time I heard that, I would no longer need this role.
Can you explain that a little bit more? What you're
So the Title 19 application process, we find that this tends to be, and I would welcome anybody who is in a clinical role. I'm not speaking from a data perspective. Thinking through the Title 19 application process, that it tends to be lengthy, but it is not necessarily solely the result of the of any, let's say, state agency. This could be, it's intertwined with family providing documents or understanding and making sure that all the requirements are in and met. There's just a lot of process to that. And then in addition to that, ensuring that there is placement for individuals who would be on Title 19 after the application were to be approved.
okay.
Could we just add in there the whole, and maybe it's already included and I'm too concrete, but the discharge pending issue? I mean, I'm sure every hospital is facing this, but we have had multiple cases of people who are here months while the family is either getting the forms or not getting the forms, or the conservator has it, people have property in Maine that's got to be evaluated. And while they're waiting for all that to come in, they're sitting in the hospital for 30, 60, 90 days because years ago, SNFs used to take people with Title 19 pending, and now they won't. And I get it because they didn't get paid. They got shorted a lot. But that is a huge issue. The whole discharge pending issue. Title 19 pending, because at the beginning when we talked about how the authorization process, I don't know if this was the case during COVID, but if you didn't have to verify that people had coverage and you were still able to refer, but Title 19 pending is a huge issue, both in medicine and in behavioral health. And often what happens is, at least I'll speak from our small behavioral health unit, is because we know it's going to take so long to do the Title 19, we do get them conserved. We do ask the conservator to start the process, but we discharge them, and they may come back 1 or 2 times after that because really what they need is placement. But there's no way to get them placement.
And I guess to shift a little bit into thinking about solutions, I believe there are other states who have established funds to basically bridge that if it's anticipated that the funding will come through. I don't know how many states have done that or how successful it's been or if that would be viable in Connecticut. Has anyone heard or seen experiences with that being successful? Okay.
Some of us have taken that on as an expense ourselves to try and make room. So maybe as we talk through that particular one, we can talk about what other solutions might be out there. But that is not a viable option for many places.
Right, and I just want to mention that some changes in the federal law are now going to make this even worse because currently in Connecticut, you can't make someone a condition of admission that someone pay for their family member, but you could make them promise to help apply for Title 19. And you're not going to be able to do that anymore. So you're not going to be able to hold the family to their promise or to their obligation to assist in the application process. And that's going to make it a lot more difficult for nursing homes to take someone who's not yet applied for Title 19.
And Mag, what was the federal law that caused that?
It was a CMS, it was changed that CMS had made, and I believe it might be part of HR 1. Tracy, was it part of HR 1? Around the same time, or the new rules of participation, you can no longer, they made it very clear, you could no longer not only hold someone responsible, which you couldn't do in Connecticut anyway, but you could not require them to help you with the Title 19 application. So that's going to be very difficult.
Well, I think the other piece about HR 1 too is the reducing the retroactive time frame from 3 months to 1 or 2, depending on the group. But that's primarily Husky D, which would be a lot of your behavioral health.
Yep. And then we were just talking today about Maine. I think it was Maine, right, Tracy? Tried to make some changes where they would put a pot of money aside so that
for the conservatorship piece.
There was a conservatorship piece, and then they tried to pass a bill that said there would be a pot of money that the nursing home would be paid, and then once the application was granted, the money would come back. But there was no answer to what if the application was never granted. Because you can't guarantee that someone's application is going to be granted.
So Chris, this might be one, as we dig into a couple for all of us to spend some time on to understand what the new laws are, the implications of them, because I'm not sure all of us on the hospital side know that or understand that. And then is this something that one of the things we might be able to work on coming up with a potential solution?
And there's also that conservator work group that's working.
Yeah.
So sort of maybe coordinating a little bit with them too.
And tell me more about that. Is that
it's a legislated work group, and they're really they're trying to recruit people to be conservators. They're trying to increase what they can get paid to make it more of an incentive for people to come in to become and really take on the conservator role in a professional manner so that things can move swifter. And also, is there more they can do to have DSS cooperate with them so they, because it's one thing as a family member to try to get access to all of your bank records. They're finding it even difficult for the conservators to work with the financial houses and to get people's, that those 10 shares of stock they have in something. So they're trying to find a way to make it sort of easier for the conservator to apply for Title 19.
Okay. Marcy, did we finish your list?
I only have one more, but you say that the Title 19 one is always a really big bucket. The last one I have is history of violence or criminal activity. One of the ones that has come up since then that that you've mentioned earlier in this is homelessness. That did not end up on our list, but has been talked about since as potentially being an addition.
Marcy, I'm curious on a couple of things. Under the Title 19, you talked mainly about the application process, timing, and ability to get the information. Is there anything about reimbursement? Because I know from our perspective, agencies can only take so much. If they take Medicaid, they can only take so much of it, and then they have to say no. So that's a stopper in the hospital. You're not going to be able to get somebody out. And then the other one is primary care, lack of primary care in the community. And we have to have primary care in order to be able to serve home health and hospice.
The funding is always a topic.
I was just surprised it wasn't on any part of your list. So
it is. That would go in. CHA has routinely raised Medicaid underfunding as being like a big bucket that has,
Yeah.
you know, many tentacles into different areas. But to your point, we did not specifically call it out here. And then the primary care one, again, like I know these are big bucket categories. It's just, you know, when we're asking the hospitals and the case management team to go in and start tracking these, we wanted it to
Yeah.
be as light of a lift as possible.
Understood.
So there's a lot rolled up into some of these categories. So that primary care would go into the lack of follow-up outpatient or home care. But yes, that's that sort of thing, or lack of ability to come back for, say, testing or, you know, see the specialist for a follow-up, something along those lines.
Yeah, the other piece when you talk about the SNFs is whether you're looking for a long-term or a short-term placement, right?
Mm-hmm.
And for a post-acute care payment, placement, then you have to look at what the Medicare payment's going to be, and that's where your prior authorization comes in. Are they Medicare Advantage? And we were just also, Tracy and I were just talking about this morning. You know, what is their medication regimen? Because the SNF is going to accept the cost. They have to pay for that full cost of whatever medications they're on, not just what they're on for post-acute. So that can be a real barrier. And then for the long term, it's more of, do they have a bed? Are they on Medicaid? Do they have a payer source? Payer source is just critical for the long-term placement.
Good. So that's a great place to start. I mean, certainly a lot of these things are going to cross over, and figuring out how to put them into the best categories will be a little bit of a challenge. Senator Armour.
I'll just add a few more things to the list as well. One is we talk about workforce shortage in some aspects. So I think that's going to be something, I don't know if we touched on that at this point. And another thing is um, I think there's some infectious diseases which actually make it more difficult to discharge individuals, like C. diff infection and MRSA. There are limited beds, and tuberculosis as well, isolation restrictions. Then I also know that transportation becomes an issue from a discharge for a patient. So that's one of the reasons why we are not able to get the patient out in a timely. Oh, it's already there. Sorry. And there's the homeless part. I think we need to probably highlight that. I know Sarah Fox is going to try to meet with the leadership of the committee to talk about that, because we are seeing a number of those cases in the emergency room. It's clear that the patients come in because there's no safe place for them. Another part that I see from the discharge is that the homes are on the second floor, and person has to go up the stairs. So, and they are well enough to be out of the hospital, but not well enough to be in a rehab facility, but they don't have a way to get into their home. And that actually sort of keeps them in a limbo as well. And I think there is the facility timing. So for a rehab facility or acute care rehab or long-term care, after like 4 o'clock, some of the places say we won't take anybody. We don't have the staff to do the intake. So that's a big thing, that if you're not able to get them discharged beyond a certain point, then the person has to go to the next day. And I think that may be a good conversation to have as well, because as soon after a certain time, and every place has a different time limit for acceptance and staffing presence there. So I wanted to put that on the list as well. Thank you.
Great, thank you. Terry.
Thanks, Chris. I think just to tie in, and it probably isn't already in all our minds, but the issue of homelessness, it is next to impossible. First of all, you can't get home care if there's no home. But the other thing is when the person doesn't have a home, then the rehab, the short term will not take them, because you have to prove that you have a discharge for after when they're completed with their discharge. So that often prohibits people from getting admitted. They may qualify for rehab, but because they're going to be homeless afterwards, they won't take them. I think one other thing, and I don't know what category it would fit in, but certainly when we have DSS and DMIS up there, but we should have DDS up there too. And the issue of group homes refusing to take people back. or take them out of the ED. So they bring them to the ED and then they say they're not safe, they can't come home. And then they really don't require hospitalization, but what do we do with them? So it happens a lot with DDS, but it also happens with DMIS.
Thank you. Okay, so there's certainly some of these that could probably be combined or put together into categories. But as far as we're brainstorming while people are here, are there things that we've missed? Just looking at it right now. I'll try to put this together and look at it a little bit more carefully. And I don't know, Marcy, if you have any other more detailed sort of descriptions of that, like in any way that you can share coming from CHA, that would be helpful. But I think hopefully you have an idea of this stuff. Donna?
So we talked about the conservators, but I just want to add that there's one other barrier here, and that's how long it takes for probate to hear these. Some regions, some areas can have their hearings within a week to two. In the Norwich area, it's a minimum of 60 days to get a hearing for a conservator. So I don't know if that's really outside of the scope, but I think from a legislative perspective, I just don't know if there's something we can do to expedite the court process to assign a conservator and then move from there.
Yeah, Donna, you that is a definite challenge.
Yeah.
Like, there's nowhere that these patients can go in between. We even have a
Exactly.
struggle just anecdotally, right? So we have Danbury has two campuses, one in New Milford. And New Milford is really where we have folks who are staying a long time, typically go. It's a lesser level of care, if you will. And if we start the conservatorship process at Danbury, we actually can't move those patients to New Milford because it's a different court unless we want to bring the patient back to the hospital at Danbury for their hearing. So that's a good one. Thank you for bringing that up.
Welcome. And may I make one other comment? When I had a conversation with Commissioner Duchani when we had the opportunity to connect at the CHA meeting, and one of the some of our really complex patients, I think you've all said this, but my feedback to her was that our commissioners across different areas do not work together. Behavioral health, adolescent in our behavioral health units, and, trying to care for them when really the whole, DMA, DMS and DSS and, they all need to work together for some of these really complex patients that need to find a place.
Okay, great. We have about 10 minutes left. We want to spend a little bit of time on just housekeeping stuff, but I did, want on the agenda, we had, solutions, which is the other side of this, and just starting to think about that. And people may have ideas, especially if they've seen other approaches in other states, in speaking, with CHA, for example, and looking at some of the things that they've proposed in the past. Certainly, funding is an issue. Everybody I talk to says that is a huge issue. We could think about how we might want to specifically ask around those things. Workforce issues. I know there are some state level initiatives to address that. Probate issues. I'm hearing that is something that there's a work group on, and maybe we can at least back them up on that being an issue for our work group as well. Given the time is very short, and we'll probably save a lot of this for the next meeting, are there, things that people want to start thinking about as far as what we're going to propose for solutions or put on a list? I know that's a very broad question, but I'll throw it out there. Gina.
So not really any specific solutions, but I'm just thinking as we're kind of going through all these different, kind of categories, to me, this is like, I would love to kind of visualize this in almost like a level of influences, right? So I think we have like federal and state policy level items here. We have community level items here. We have hospital and other facility level hospitals factors here, the interpersonal, and then the individual. So I think just, I've always been kind of a visual learner, but I'm just thinking like if we can kind of map it out at each of those levels, we may better understand how solutions are going to directly affect one level and perhaps have a trickle down effect as well. So just something to consider for our next meeting.
I love that. And I might take you up on that if you want to work together on a way to figure that out and display it, I think, for the legislature and for us to understand. I think some sort of working document on that would be great. So we probably don't have time to totally go into that, but I may reach out if that's all right.
Yeah, happy to.
Other thoughts on this? Okay. Well, we'll certainly be working on sort of the survey mechanism, and I'll try to send out a draft as soon as I can this week, maybe in a few days for feedback. I'll talk with Jen. Ideally, we would try to put this out, I think, before the next meeting, which is December 15th. So I know time is tight. I know it's the holidays. I know everybody's busy. But the ask would be to just keep your eye on your inbox and try to respond if we send something out, either a draft or something you want to weigh in on, or if we can actually get a survey. It'd probably be a Qualtrics thing that I would send out, and we'd try to get everybody in the group to participate. I might send some follow-ups and then can try to put that together for the meeting on the 15th. So the other issue is just thinking ahead again. The supposed deadline for this group is, I believe, January 15th of 2026, just coming very rapidly. We do have a meeting December 15th, and it will be the holidays. In January, the first Monday is the 5th, which is pretty soon after the holidays. And also the 19th is, I believe, a federal holiday. So my thought was proposing maybe the 12th for the next meeting. And feel free to say if that is terrible. Jen, does that work for you? I guess that's one of the more important.
Yeah, no, I think what we had talked about, I think prior to and at the last meeting, was if we could get on a regular cadence, just checking, does this time and day seem to work for everyone? And then we can just really populate with a bi-weekly meeting schedule for the next couple of months to at least make sure it's on folks' calendar, recognizing, we had talked early on that Chris and I will need to formally request an extension for the report, but we don't want to let time get away from us in terms of just really having a nice cadence and making sure that we've got some momentum. So I think that's what we would propose, right, Chris, that we would start on the 12th and then meet every other week.
Yeah, we can see how that goes, and if we need to, spread it out, or obviously, yeah, we'll see what the time frame is with the legislature and trying to get things in this session versus stretching out even further if needed. So that would be the proposal, unless anybody has any discussion, questions, comments on that. Okay. So action items are to really try to get the survey together, meet again on the 15th. Please send any agenda items or things you want to put on the agenda for discussion. Is there anything else anybody wants to bring up while we're all together right now? Okay. All right, we'll give you a few minutes back your afternoon. Jen and I will convene. Definitely feel free to reach out. We will be in touch. And thank you, everyone, for your time today.
Thanks, everyone. Have a good week.
Thank you.
Thank you.